Let's find a few people with knock knees for you to look at. And then let's see if there are any coaches who look from top to bottom. Whether it's yoga, Pilates, or fitness coaches, they generally look from bottom to top, unless, of course, it's your private training client. From childhood, from kindergarten all the way through university, they have always been sitting. After graduation, they went straight into a government office and started working, which also involves sitting. In other words, they have been sitting for decades and have rarely stood. In this case, it's possible that after their pelvis has been tilted, compensation starts from the pelvis downwards, all the way to the feet. It's also possible those wearing shorts or tight pants with X-shaped legs can come up. Let's see one or two. The main point is to teach everyone how to identify these leg shapes. Come on, have you been practicing since you went back? Singapore, let me see. You are much better than in March. This is from when you came from Singapore in March. Much better, right? They've been practicing much better, Right, step forward, step forward. You guys find one. Find someone with X-shaped legs. This one. Is it this one? It doesn't matter. Theirs is obviously better than yours, so we'll go with them. Take off your shoes and socks quickly. Which one? The yellow one? Come, let me take a look. Stand here. You don't have it as severe as them. You two stand in a row. Is it still the green shadow? Right, you go down and be the referee first. Roll up your pants and stand up there. Look, for him, once the knees are together here, the gap between his inner ankles is quite large. That must be 7 or 8 centimeters. His upper part is already together. Normally, for some people with knock knees, in severe cases, neither the top nor the bottom can touch, but they are all rotated inward. And he has obvious bunions, right? Yes, it's bunions and flat feet. Now, let everyone see your heels. Is it calcaneal varus or calcaneal valgus? Well, he doesn't have calcaneal valgus, especially on the left leg, right? Right, especially the left leg. Where is his support? On the right side. Let me take a look. Let's check if he has structural leg length discrepancy. Have you ever measured for leg length discrepancy? No, I haven't measured it. Even though it looks like he's bearing weight on the right side, but his left side is lower and his right side is higher. His sacroiliac joint is lower on the left and higher on the right. I mean, the height of the posterior superior iliac spine. And the difference is actually quite significant. It's like this. The difference is quite large. So some structural leg length discrepancies can be like this if it's a structural long leg. With a structural long leg, it will cause the posterior superior iliac spine to drop, and at the same time, it causes knee valgus, hallux valgus, and arch collapse to make that leg shorter. Of course, I don't have time to measure all of these. Do you have any discomfort in your legs? No. Do you do any exercise? Yoga? Do you do any other exercise besides yoga? No? Do you have snapping hip? No snapping hip. There's a bit of an issue inside both hip joints, on both sides. Is it greater trochanter bursitis? Then you have impingement. There is fluid and inflammation inside both hip joints. It's a good thing you didn't go running. You see, there are 2 types of people with hip impingement. Either it's instability, where the gap inside is too large. For example, their femoral head is constantly in internal rotation, which is commonly known as subluxation of the femoral head, where it's adducted and internally rotated. So in this case, every time they land, they experience an impact. Then there's another type, which is the gap is too narrow. The reason the gap is too narrow is, for example, your ilium is flared out too much. Hand me that pelvis model. Let me show everyone. The movable femoral one? Yes. Let me tell you about hip impingement because I've encountered so many cases. The most classic case of hip impingement is Mr. Shen Teng's. He was told at Peking Union Medical College Hospital to get a femoral head replacement because of hip impingement, but he didn't want to, so he came to us. And then this is the acetabulum. The acetabulum has a larger surface area on top and is narrower at the bottom, and it also has a notch. For many people, how does the impingement happen? It's not that the femoral head has changed, but the top of the acetabulum has widened. It's like this. Because of this, their femoral head gets stuck right in this position. So at this point, the muscles around the hip joint can only relieve the pressure on the hip joint after they are fully relaxed. So you need to reduce the contact area above, and you need to allow the ilium to adduct and internally rotate. In this way, it won't easily impinge on the top. In other words, hip impingement isn't actually a hip problem. It's a problem with the pelvis above and the feet below, which just manifests in the hip. I've encountered too many cases like this. Also, I've dealt with many cases of ischemic necrosis of the femoral head, many within grade 2, and I've also encountered grade 3 cases, as well as those who have already had a femoral head replacement. You'll find that even after the replacement, they still experience pain. It's possible that after the surgery, the hip joint doesn't hurt anymore, but then lower back pain starts to appear, because their proprioception in this area has been affected. However, even after the replacement, they have consulted countless experts, and not a single one has been able to figure it out for them. Why does it keep impinging here? You tell me. Her training intensity is much lower than ours. She's a yoga teacher and doesn't do weight-bearing exercises. We carry 500 or 600 kilograms and do this every day, yet we don't have any impingement. She's a yoga teacher who just walks around and practices some simple poses, so why would there be impingement inside? Therefore, it might be related to the state of her acetabulum. The contact area between her femoral head and the acetabulum has increased. Plus, what's inside it? The position of the femoral head, it might have rotated inside, so at this moment, it maximizes the contact area, making it prone to impingement. And every time you finish loosening up the fascia, the tensor fasciae latae, or the hip muscle groups, it might feel smoother and more comfortable. But when you perform movements that cause your body to splay open and you put it in a closed chain with weight pressing down on it, it's still splayed open like that at the top. You can also understand it this way. As long as it's not someone running a full marathon every time, and it's just impingement from walking in daily life, as long as it's like this, you can understand it as their calcaneus failing to control their ischium. In most cases, with over a 95% probability, the ischium has shifted inward. Because their ischium has shifted inward, the further inward it goes, the greater the contact area on the upper part of their acetabulum. The greater the contact area with the femoral head, the less the foot can absorb shock, and it cannot use the foot muscles to control the back of the lower leg or the back of the thigh. Therefore, more force is pressed onto the joint, making it prone to impingement. And what's more, when it impinges, it happens bilaterally. Even though there's no clicking sound, there's inflammation on both sides, along with a lumbar disc herniation and bilateral hip joint effusion.